So let's see Brown syndrome. There is a main feature for Brown syndrome, or like a hallmark for Brown syndrome. So as you can see in this photo, you have two girls. So both girls are looking like dextro elevation. We have a problem in their left eyes.
Defective elevation in adduction.
So this is like the hallmark for Brown syndrome, which is the limitation, as you said, Dr. Hasika, limited elevation in adduction. It's not only this, there is somehow downshoot. Remember, downshoot. There is downshoot in her left eye. So it's not only doesn't elevate, but also there is some kind of downshoot. And we will see later, there is one of the feature also of Brown syndrome is widening of palpebral fissure on adduction. So the opposite for Duane's. So Duane's, we have narrowing on adduction, and here we have widening on adduction. This is an additional feature for Brown. But the main feature, as you said, Dr. Hasika, is limited elevation in adduction. Additional feature is downshoot and widening on adduction.
Widening in adduction is always there, ma'am?
No, this is an additional feature. It's not essential feature. It could be present or not. We have an old name for Brown syndrome, but I like this name because it will remind you by the pathology, which is the superior oblique tendon sheath syndrome. So here the etiology for Brown syndrome or the pathology is restrictive at the level of the superior oblique tendon sheath trochlea. So this area, we got a restrictive component. So I like to contrasting Duane syndrome by Brown syndrome. So in Duane, this is now considered as CCDD. It's not restrictive, neither paralytic, or it is a combination of both. But Brown syndrome, it is restrictive strabismus syndrome. If you like mnemonics, here one participant said that Brown syndrome, it reminds him by Brown cataract. So in Brown cataract, it's so hard. So means this is the abbreviation for superior oblique. So we have a tight superior oblique. We have restrictive at the level of the superior oblique. All right. If you like mnemonics, I will show you just 3 cases here. This is from New Kanefsky, and this is the primary position. So Dr. Eva, can you comment on the primary position based on the Hirschberg test?
On primary position, the Hirschbergs look central.
So it seems to be an orthotropic, all right? And here?
On dextro version, there is...
So actually, this is a kind of dextro elevation.
Okay. On dextro elevation, there is slight limitation of elevation in the left eye.
But it's, yes, it's so mild, like subtle. So there is slight limited elevation in adduction in the left eye. And how about the bottom photo?
This is dextro version. Okay. There is
some downshoot.
On dextro version, there is a slight downshoot.
Okay, so you have commented on the ocular alignment and the limitation of movement. But again, we forgot the comment on the palpebral fissure. So compare here the width of the palpebral fissure. So it seems to me that both eyes are became wider, but ignore this for a while, but focus on the left eye because this is the left affected eye, the left Brown syndrome, and you can appreciate the widening of palpebral fissure. All right.
Is this an essential feature, ma'am, or is it only in some cases?
In some cases.
And downshoot is also only in some cases.
In some cases, yeah. The essential feature is limitation of elevation in abduction. So as you can see here, it is orthotropic because sometimes we get hypotropia. Because if you think for a while, if we have a restrictive element at the superior oblique, and superior oblique is a depressor muscle, so it takes the eye down. So in some cases of Browns, you will get hypotropia in the primary position, and we will see it in the moment, okay? But here, New Kanefsky presented us with a mild case of Brown syndrome in the left eye. So in summary, this is a case of, I can say it's mild Brown syndrome because it is orthotropic in the primary position. And we expect that there is no abnormal head posture. And there is subtle limitation of elevation in adduction and a slight downshot and widening of palpebral fissure. So here is the comment: left Brown syndrome, limited left elevation in adduction or dextro elevation, straight eye or orthotropia in the prime position, and downshot in adduction. So now we have like 3 causes for downshot. It could be the most important one is what? Superior oblique overaction. The second one is Brown syndrome. The third one is Duane syndrome. So try to make like a list of differential diagnosis. So again, the main feature, or we can say the hallmark, it should be limited elevation in adduction. So whether inversion or adduction. So if you suspect the left Brown syndrome, if you cover the right eye and to test the elevation in adduction, it is still limited, all right? So other feature, it could be present or not. So if we have a significant Brown, we will have hypotropia in the primary position, all right? Because again, the superior oblique is a tight muscle and it is a depressor, so it takes the eye down. Additional feature, it could be present or not, downshot and widening of palpebral fissure in adduction. Ignore now the abnormal head posture. I will say it in a moment. If we have a severe cases, there will be also limitation of elevation in abduction. So all up gazes will be affected. But if we have a limited elevation in adduction and abduction, you have to compare. What's the meaning of comparing? Let's draw it. Suppose we have a Brown. So this is a severe case of Brown. So we will get hypotropia. This is, we have a Brown syndrome, OS. So we expect hypotropia in the prime position. And you are testing now the dextro elevation. It will be affected, like marked limitation. And in abduction, it will be also affected, and here it will here affected. So you compare the limitation in Brown syndrome, the maximum limitation is still in dextro elevation, or in this case, like in up and in. So once again, in severe cases, so this is a severe Brown syndrome, you will get limitation of elevation in all up gazes, but still up and in is the most affected movement. Got it? Suppose we have a case now of hypotropia or orthotropia, and you noticed limited elevation in adduction. And this is the hallmark, as I said, but still, this is not the confirming feature. You have to confirm the diagnosis by what? Do you know? Remember, the etiology is restrictive.
Reduction test.
Yes, excellent. So whenever we have a restrictive or you suspect of restrictive component, you have to do forced adduction test. So I want to stress on a point here. You said forced adduction test. So you have to say positive forced adduction test. Still, the sentence is not complete. You have to add, we have a limited elevation of the eye up and in. So this is the hallmark again, but you are feel it. This is like something you feel it. This is something objective. You find it by doing the forced adduction test. So the final confirming feature for Brown syndrome is having positive forced adduction test in up and in movement. All right. And this is from old Kansky. Let's go one by one. Here is an advantage because he presented us with a case with abnormal hip posture. Can you comment on the head posture in this case? If you remember, sometimes the abnormal hip posture have more than one component. So if we have all components, we will get something in the chin elevation or depression, right or left head tilt, right or left face tilt. So what do you see in this photo? The most prominent component here.
Ma'am, chin elevation, ma'am, right face turn, and left head tilt.
Excellent. So how we expect this abnormal hip posture? So what is the problem here? We have a restriction at the superior oblique. It is a depressor muscles. The eye can't move up, generally can't move up, especially up and in. So the worst gaze here is up. So the head is turned to the worst position. So we have chin up. So whenever we have a problem in up gaze, we will take the chin up position. So this is number one. I don't know if you can see this. If we have a chin up. And there is a general rule, and it will help you. It's like mnemonics. It helps you to remember the abnormal head posture. Regarding the tilt, the head tilt is generally on the hypotropic side. By the way, this is a left Brown syndrome. The left eye is the affected eye. So whenever we have hypotropia, the head tilt is always on, like generally like 90% on the hypotropic side. So we have left Brown syndrome. So we have left head tilt, as you said. So we have left head tilt. And this is the, to make it a general statement, we can say ipsilateral head tilt. How about the fester? The problem here, the left eye cannot or can't elevate in adduction. So it looks like what? It looks like the inferior oblique palsy. The inferior oblique can't function because of the restriction. So again, the patient cannot elevate in adduction. So in this gaze, in this dextro elevation, okay, we have a problem. And the face will turn to this gaze, to the right side. So this is a contralateral face turn. And if you remember this slide, whenever we have three muscles are acting in adducted position. So the medial rectus is adductor, the inferior oblique elevates in adduction, the superior oblique depresses in adduction. So if we have a problem in these muscles, like in this, we will get contralateral face turn. So if we have medial rectus under action, we will get contralateral face turn. If we have an inferior oblique palsy, you will get under contralateral face turn. If we have a superior oblique palsy, you will get contralateral face turn. So here in Brown's, the net result is defective elevation in adduction, as if it is inferior oblique palsy. So you will get contralateral face turn. Okay, so chin up because she can't elevate her eye. So this is the worst position up gaze. So chin up. Ipsilateral head tilt because the head tilt is almost on the hypotropic side. Contralateral face turn because we have a problem in the adducted position. Whenever we have a problem in adducted position, because the adducted position work on the contralateral side, so we will get contralateral face turn. All right. Now coming now to the, let's see, the primary position.
The corneal reflex looks central for me. So the eyes are in orthotropic position in the primary gaze.
So it looks as an orthotropic patient.
Coming to the picture B, on dextroversion, there is some downshoot in the left eye.
Yes, and
widening of palpebral aperture in the left eye.
Yes.
Dextroversion.
In up gaze?
In up gaze, there is defective elevation in the left eye compared to the right eye.
Yes. So actually in Kanisky, he mentioned this position as a slightly dextro elevation. So there is limitation of elevation in adduction and also in straight up gaze. But how about elevation in abduction?
Is normal, looks normal.
Looks normal. Let's see the comments. It is a case of left Brown syndrome. So we have a straight eye in the primary position. somehow we disagree with him because if it is a straight eye in the prime position, why she adopted this abnormal head posture in the first place? So it is confusing for me. It may be mild hypertropia, I believe. And he said limited lift elevation abduction, limited lift elevation up gaze, and normal. So whenever we have normal elevation in abduction and limited elevation in adduction, this is most probably this is a case of Brown syndrome. The last photo is confusing, so I omitted. Coming now to the etiology, not the pathology. We mentioned the pathology. We have an issue, let's say an issue in the superior oblique, a restrictive issue or something problematic that makes the eye can't move up and in. But if we are now talking about the etiology, it could be congenital or acquired. Compare this with Duane syndrome. Duane's is almost always congenital. So the next question, what are the causes? Just 2 causes or 3 causes for acquired Brown syndrome.
It's mostly congenital, ma'am.
Yes, most commonly it is congenital. So my question was about acquired. She said
acquired causes could be because of trauma or inflammation at the trochlea.
Yes.
Or sinus infection.
So avoid to say trauma and stop your sentences. Like you have to say trauma at the area of the trochlea, okay? And
yes,
don't say just inflammation. Give me an example of inflammation that might cause Brown syndrome. So because if you say trauma, inflammation, so you are you vitamin C or the mnemonics, congenital, inflammatory, traumatic, neoplastic. So you are actually not saying anything. So so here I wrote here in inflammation, rheumatoid arthritis. So in my medicine Viva station, one of the questions was about the ocular manifestation of rheumatoid arthritis. And when I said acquired Brown syndrome, the examiner was like so satisfied or so happy about my answer. And he forget about other mistakes. I believe he gave me the passing mark because of this answer. And again, sinusitis could affect the area of the trochlea and cause acquired Brown syndrome. Trauma in the area of. So I added iatrogenic. So we have 2 common causes for iatrogenic Brown syndrome. Again, if we have a surgery in the sinus area, so sinus surgery, okay, and there is squint surgery that might cause Brown syndrome. Do you know superior oblique palsy? There is a surgery for superior oblique palsy called the tucking. It is a muscle. It is a surgery to strengthen
strengthening the muscle,
strengthening the superior oblique tendon. But one of the complications that the strengthening is too much and it leads to contraction in this area. So the tucking surgery but it's really done nowadays. This is a squint surgery that might cause acquired Brown syndrome. The point here that when you ask about the etiology, first you have to say there is some congenital and we have congenital and we have acquired, because the case could be an acquired Brown syndrome. So here I wrote V pattern, but I didn't have time to look for a case that shows V pattern in Brown syndrome, but this is the most described pattern in Brown syndrome. Unfortunately, I got this composite photo from this book, but he didn't incorporate the down gaze, so we can't judge. So let's we always start by primary position. What do you feel? Sometimes we say, what do you feel? What do you think? Because again,
ma'am, actually, I feel that in primary position, the left eye is mild. I don't know if it is relevant, but it appears to be like proptosis when compared to that of the right eye. And it's more prominent, and there's mild exotropia of the left eye.
Okay.
Ma'am, there is right face turn, ma'am.
Okay, so I was about to say this. This is the primary position, but there is abnormal head posture, but it is not evident clearly because the photo is cropped. and this make a difference in the magnification. So the left side of the face is closer to the camera than the right side. So this might be a factor that you appreciated a bigger, prominent left globe. This is one thing.
Yes.
The other thing, when we have an hypertropia, now imagine now we have a hypertropia, so the upper eyelid now
comes down. The palpebral aperture should be small.
I mean, sometimes, not all cases of hypertropia, we have pseudotosis, okay?
Okay.
Sometimes we have hypertropia without ptosis, as in this case. So in this case, there is hypertropia. So the upper eyelid actually in touch with the superior limbus. So normally the upper lid should cover like 1 or 2 millimeters of the cornea, but here it is in touch with the superior limbus. So this again gives us a false impression of proptotic globe, because when we have a proptosis, sometimes we get a rim of the sclera above and below the limb. So two factors gives this prominent or the impression of proptosis: the hypertropia and the difference magnification. And she said exotropia. Actually, this is not a prior position. Somehow, the patient is looking a little bit to the left. The right eye is slightly coming in, because actually the patient is looking somehow to the left, all right? But again, the most prominent feature here, you can justify by answer. You are just describing what you see. So if you even said it looks proptotic, it looks exotropic, but don't miss the prominent, the essential feature here, which is the hypertropia. Coming now to the
yes, ma'am. On dextroversion, there's actually a downshoot of the left eye.
Okay, and ignore the widening, because the girl already has a wide palpebral fissure, but the most striking feature here is downshoot. So you have to think what are the causes of downshoot in your mind. And in Levo version looks nice, okay, right?
Yeah, Levo version is good.
Let's see the elevation. So here in dextro elevation, this eye elevates, but this eye,
restriction of elevation only.
So we
dextro elevation.
So although you know this is a restrictive, because we already know this is a Brown's, but say at this moment limitation of elevation in adduction. Don't say restriction, although it is a restrictive in this case. And here in straight up gaze, in like direct up gaze,
there's again limitation of elevation.
Yes, elevation. And as you can see, when we look above, the eyelids retract, and the eyelid in both eyes retract, but the eye doesn't move, and that's why there is a marked area of white sclera above the cornea. Scleral show. Yeah, scleral show. And how about elevation in abduction? It is still affected.
It's still affected, yeah.
But compare it by this one, okay? You will find, or you may feel that the limitation in adduction is more. So if you are confused about the up gaze, the downshoot points to Brown syndrome together with the limited elevation. So this is a case of severe Brown syndrome. The down gaze is expected to be okay. And he also didn't elevate the eyelids to comment. So what do you think is the etiology of this Brown syndrome? It is a child with suggestive features of Brown syndrome. And as you can see,
congenital.
So this girl has suggestive features of Brown syndrome, because I need to confirm it by positive force adduction on adduction in up and in, okay? Let's see, this is the author's comment. It is a case of acquired Brown syndrome. Having a Brown syndrome in a child doesn't always signify congenital etiology. So you need to take history about the onset of Brown syndrome, because actually in this case, the author mentioned that this is an acquired due to inflammation in the area of the trochanter. So having a strabismus in a child doesn't always signify congenital etiology. It could be acquired, it could be trauma, it could be anything. So you can't judge the etiology from the picture. you have to take history and do examination. So if you have an inflammation, she might complain of pain during the elevation.
Ma'am, can we offer a DD of double elevator palsy and all? Is this in this case, ma'am?
Okay, so let's see here. Suppose the examiner tell you what are the differential diagnoses. He seemed to be unhappy with your like one diagnosis answer. So in this case, we have hypotropia, OS, and we have like defective elevation, and you are confused. You can't judge about the which is more affected. Is it this one or this one? So you will say the list for the differential diagnosis of hypotropia with limited elevation. So first you have to cover the other eye to be sure that the limitation is still there. Okay, so the most two important differential diagnosis is Brown syndrome, but since there is here defective elevation, you can add severe. And we have here in this case, the previous case, another feature suggestive of Brown syndrome, which is the downshot. So downshot is one of the characteristic feature of Brown syndrome. So that's why I wrote Brown syndrome number 1 in this case. The second possibility, someone said double elevator palsy, right? Nowadays, we give a better term for double elevator palsy. It is called
monocular elevation deficit.
Yes, excellent. Monocular elevation deficit. And monocular elevation deficit is subdivided into 2 types: inferior rectus restriction. So if you think if the inferior rectus is tight or restrictive, this eye can't move up, okay? Or it could be, as you mentioned before, double elevator palsy. Something affecting the superior rectus and the inferior oblique, supranuclear. So the elevator muscles, like palsy in the elevator muscles. So again, the eye can't move. How we can differentiate between all these cases? Force reduction test.
Reduction test.
So in inferior rectus restriction, you will find restriction in all gazes. In Brown syndrome, you will find restriction only in up and in. In double elevator palsy, there is no restriction. So in Brown syndrome, there is positive force reduction, but in up and in gaze. Okay?
Yes, ma'am.
In inferior rectus restriction, there is positive force reduction in all gazes. In all gazes, like up and out, up and in. All gazes, all the 3 up gazes.
Yes.
In double elevator palsy, there is here a negative force reduction test. So here we have positive force reduction test, and in between brackets, up and in. Up and in.
Is only up and in.
But
the question was even in case of severe Brown syndrome. So in severe Brown syndrome, we are having on clinical examination, there will be restriction on all up gazes, but it will be more in adduction. So when we do positive force, when we do a force reduction test, we'll find that the restriction is only in the up and in position, not in the other up gaze.
Yes. What you are saying is correct. So
okay.
By observing the case, like in clinical, at office or at clinic, in severe Brown, you will find limitation in all gazes, especially the up and in. But in doing the force reduction test, you will find only the limitation up and in. Got it? But in inferior rectus restriction, you will get force reduction test in all up gazes, up and in, up and out. And again, the force reduction test for obliques is different from the force reduction test for rectus muscles. Technically, there are some different. We will say it in a few minutes.
Ma'am,
Yes.
can you discuss briefly about the management of Brown syndrome, like surgical management, or what is it?
Okay. The question is almost always about the surgical indication when we interfere surgically.
Okay.
So if you remember from Duane syndrome, this is a squint case. You have to go through the standard care. You have to do psychological refraction. You have to fundus examination, everything. Because sometimes the child have amblyopia, refractive error. You have to address all these problems. And how about surgical interference for Browns? When we have, again, significant abnormal hip posture, severe Brown syndrome. So here you can surgically interfere. I think it's well written in Kanetsky. But what is the name of the surgery? We do something called superior oblique elongation surgery, because one of the theories that the superior oblique tendon is short and tight. So we have to elongate the superior oblique tendon. So we can use silicone, like a piece of silicone. This is Kenes-Wright procedure. And we can use something called Z elongation. You know, Z plasty in skin surgery, in skin for scars, something called Z elongation of the superior oblique tendon. So we are trying to elongate the tendon. This is one principle. So you have to know only the principle, elongation of the superior oblique tendon. Some, let's say, in between brackets, aggressive strabismologists may do tenotomy, like this insertion of the tendon. And if you think for a while, if we do tenotomy, you will get inferior oblique overaction. You actually convert the case into superior oblique palsy. If you do tenotomy, this insert the superior oblique tendon, now the case is like superior oblique palsy. So one of the common complications that you will get inferior oblique overaction, and now try to manage the inferior oblique overaction according to the degree. So this is like the two basic principles. Elongation, this is the most accepted surgery, elongation with different techniques of the superior oblique tendon. Second principle, I think it's really done nowadays, is tenotomy of the superior oblique tendon. This is for, of course, if we have an acquired cause due to inflammation or something else, you have to tackle this inflammation by anti-inflammatory drugs. So I think you can recheck the Kanetsky. It's what is written is enough in Kanetsky. Coming now to forced duction test. Generally, we use forced duction test when we have a limitation in the movement. So limitation could be paralytic or restrictive or combination of both. And when we do forced duction test for obliques, it differs from testing for rectus muscle. We will see it. Can anyone tell me about the most important examples in ophthalmology when you find forced duction test is written? Give me some examples where forced duction test is very essential step in the workup of the patient.
Differentiate a paralytic from a restrictive cause of strabismus.
Just give me more specific example. Let's say Brown syndrome.
Brown syndrome, yes.
Yes, we need the forced duction test to differentiate between Brown syndrome and monocular elevation deficiency. We just mentioned this. Another
thyroid
example.
eye disease.
Yes, thyroid eye disease. Thyroid eye disease. The most commonly affected is the inferior rectus, right?
Inferior rectus.
Followed by the medial rectus.
Medial rectus. I am slow.
So we have, yes, excellent. So we have hypotropia.
Blowout fracture, ma'am.
So we have blowout fracture. Mostly the inferior rectus restriction. So again, so as you can see, the common theme here is the restrictive. So we are trying to document or confirm the restrictive component and to differentiate it from paralytic. And if we are going to do surgery and we have a post-forced duction test at the start of the surgery, after you finish the surgery, you have to confirm that the forced duction test becomes negative. So suppose here the inferior rectus is restrictive in thyroid eye disease. So you did inferior rectus recession. So you have to end your surgery by doing again force reduction test to document the that it became negative. Okay, so that's why I said here how many times. So at the beginning of the surgery, at the start of the surgery, and at the end of the surgery, if you are operating on a restrictive strabismic case. All right, and some recommend, yes, if you are planning to be a squint surgeon, it is recommended to do force reduction tests on non-strabismus cases, like before doing cataract surgery, to feel the normal, what is the normal, because it is somehow depend on your feeling, or it is, you have to know the normal resistance in order to detect the abnormal resistance. All right, and yes, I posted this before, so just one a little piece of knowledge here. Before you do the force reduction test for rectus muscles, you have to proptose the globe. And before testing the force reduction test for oblique muscles, you have to do retrobulging. Okay, so let's see, draw the orbit here. So as you know, all rectus muscles are the origin of, here is the origin, is from the apex, and all the insertion, this is rectus muscles here anteriorly. So you have to proptose the globe a little bit to make the rectus slightly under stretch. If you accidentally depress the globe, the muscles artificially or iatrogenically is slacking. So it will give you a false negative force reduction test. So you have to put the rectus muscle under slight stretch by proptosing the globe by testing the movement medially or laterally, up or down. Because when we are testing the rectus muscles, we move the eye medially or laterally, up or down. For obliques, we have two obliques. So we have superior oblique. So the origin of superior oblique is considered as the trochlear. So this is the functional origin. So this is anterior. So the origin is anterior. And the inferior oblique origin is near the nasolacrimal duct, the bony opening of nasolacrimal duct. So here in obliques, the origin is anteriorly, and they are inserted posterior to the globe. So let's imagine now here, this is the the superior oblique. So here is the origin, and here is the insertion. So you need to do retrobulging, because retrobulging will put the tendon under stretch. If you do retrobulging, so the globe is like here, this tendon become under stretch. So the idea here to do force reduction test with the muscle under slight stretch.
For obliques, how do we check for FDT? Like we retropulse the globe, and then in case of superior oblique, to check for superior oblique restriction, we have to move the eye up and in.
That's enough. But I don't think they will ask you for more details about this. Because if you remember, we mentioned three common examples when force reduction test is very essential. The thyroid and the blowout fraction, and both for rectus muscles mainly. And the first example was about Brown syndrome. You retropulse the globe and try to move the eye up and in. Now Hess test or Hess chart test, the last part in our presentation. I said I think it's a low yield, but I don't know, some very keen to know about it. I don't know why, but it's written in Kansky and it has a clinical significance, but for strabismologists. Now let's see Hess chart. So in order to say the basics behind his chart, I will need at least 1 hour. Okay. So I'm trying to say it in a different way, like because you have an exam next week. So, you know, like in ECG. So even if you don't anything about the mechanism for the waves, you're still able to pick the signs. So I will try to make you able to elicit the signs or the diagnosis from his chart without knowing much about the details. And I think if you remember the video I made about his chart, real patient, and the technician is doing the his chart. So we have a lot of information in this slide. I made this slide to summarize everything, but it is crowded now. Let's go one by one. Here is the patient, all right? This is the patient is sitting, should be sitting. And the patient is sitting in front of something called his chart. And the patient is holding, this is his hand, is holding a green laser pointer. It should be green. It should be green, conventionally, all right? And here, the patient, here I draw his eyes. This is the right eye and this is left eye. If you remember from the second lecture, I mentioned that when we draw the eyes at the bottom of the slides, it means like this. This is the right eye and this is the left eye. And the patient here is facing his chart. And the patient is wearing red-green goggles. Okay. And by the way, the red-green goggles, suppose here in this slide, the red filter in front of the right eye and the green filter in front of the left eye. Because his charting is divided into 2 parts, charting of the right eye and charting of the left eye. Okay. So these goggles will be reversed. So, but in this slide, the red filter in front of the right eye and the green filter in front of the left eye. Okay. This is the patient side. The technician is standing beside the patient. If you remember in the video, the technician has 2 many jobs. First, she or he holding a red laser pointer. So as you can see here, it is in red. All right. It's suppose let's say she, because this is like a silhouette of a woman. So she is pointing, this is the central point of fixation. Suppose she is pointing at the center here. She instructs the patient to superimpose. So the patient here is holding a green light in the form of a slit. So she is pointing her red dot, let's say on the center of the fixation, and the patient is asked to superimpose, to put the green slit over the red dot to be on top of each other. If the patient exactly superimpose the green slit on her red dot, she will record. She is holding a paper, like a paper of his chart. She will record that this point is exactly on the fixating point. So she is responsible for pointing, and she is responsible for documenting the finding of the patients. As you can see here, actually she is holding 2 charts, because there is a chart for the right eye and there is a chart for the left eye. You know, this is like a visual field. You should do the visual field. Ideally, you should do the visual field for the right eye, and you should do the visual field for the left eye. Sometimes we call it field, by the way. His chart, sometimes we call it a field. So in this slide, I wrote here, this is a charting of the left eye. So why I said this? Why I said charting of the left eye?
Green before the left eye. Yes.
Yes. Because in this slide, Since she is pointing the right eye behind the red filter is seeing only the red dot. So the right eye is the fixating eye. Okay, so again, the right eye, since the right eye is behind the red filter, the eye is considered the fixating eye because the technician is holding a red light. But the left eye sees only the green slit. The left eye behind the green filter sees only the green slit held by the patient. Anyway, this is called charting of the left eye. So charting of the left eye means that the right eye is the fixating eye. Again, charting of the left eye means that the right eye is the fixating eye. So I wrote here because the red filter is in front of the right eye. So the right eye sees only the red pointer. So this is the fixating eye. And we can now chart the behavior of the left eye. And this word behavior is not correct, actually. The more precise word is something called visual projection. So we are charting the visual projection, let's say the foveal projection of the left eye. She changes the area or the point of testing in some points and record in this paper to chart the projection of the left eye. Now, after she finishes the charting of the left eye, she will reverse the goggles. So the red filter now in front of the left eye. So the left eye became the fixating eye, and we are going to chart the right eye. The red filter in front of the left eye, so this is the fixating eye. So whenever we have an eye behind the red filter, this eye became the fixating eye. And we are charting the other eye.
I got it now.
Okay, and this is the normal, and that's why I posted this slide before. So as Dr. Haska said, the green in front, so the green is always in front of the charting eye. So the green in front of the right eye, so this is a chart of the right eye. But I said in other way, I said the green in the front of the right eye, it means that the red filter in the front of the left eye, so the left eye is a fixating. So we chart, we always chart the non-fixating eye. So whatever you like, which way to remember.
I remember generally green in whichever eye the green.
Okay, so
green filter is there, that is the testing eye.
So the green in front of the tested eye.
Yes, that is how I remember.
So in the front of the tested eye, and we can say the green is in front of the eye to be charted or to be tested. Yeah. And we can say the green is in front of the non-fixating eye.
Non-fixating eye, yes.
Okay. So first, before you comment on the HESET chart, you have to know the orientation. So ideally, it should be two charts. So first, suppose the examiner is going to provide you with his chart. Ideally, it should be two charts. The right is in the right side and the left in the left side, as in this slide. It's like the visual field. If you remember, in the visual field orientation, it should be the right field in the right side and the left visual field in the left side. And this is so here is a nasal side, and this is the temporal and the temporal. And this is a normal. Let's enlarge one. Like we call it the inner field. This is called the inner field. We have here in the center, this is called the fixating point. And we have the inner field. Every square is 5 degrees. Yeah. So this point represents 15 degrees to the temporal side. And this point represents 15 degrees to the nasal side. So the calibration here is in degrees, not in prism. And we have another square, a bigger one. This is called the outer field. So first, the technician point at the center, and the patient exactly pointed correctly over by his green slit over the red dot. So this is an accurate. So all the points are accurate. So this is a normal chart for this eye. And as you notice, actually this point represents the function of the muscle. So here, this is the action which eye depresses the eye in adduction, because this is a nasal side and this is a down gaze, so this is a superior oblique. So as you can see, it is written superior oblique, inferior oblique. Here the medial rectus, lateral rectus, superior rectus, inferior rectus. So let's start by the easiest example, which is the 6th nerve palsy. If you understand this example, you will understand the remaining examples, hopefully. This is an example of 6th nerve palsy, OS. Okay. So lateral rectus is not functioning here, so the antagonist is taking the eye inward. So we have here a paralytic esotropia in the left eye, ET, OS. All right. In this position, OD or the right eye is the fixating eye. All right. And the left eye is the affected eye. And suppose we measure the angle here, and let's say it's like 30 prism diopter. And this is, by the way, called the primary angle, because this is the angle of strabismus in the affected eye. Now, if we cover this eye, and it's a kind of paresis, so the eye will take the fixation, the left eye will take the fixation. So here, the brain is sending impulses to the lateral rectus to contract, and the right eye under the cover goes in. Because if we send the impulses for the lateral rectus to contract and to take the eye, to take up the fixation, at the same time, the medial rectus will take this previously fixated eye inside. So we have here an esotropia. And now imagine that how much esotropia? It should be like maybe 50 prism diopter. Because here the brain is sending too much impulses for this paralytic lateral rectus to contract and to take in order for this eye to take the fixation. So at the same time, equal impulses will be sent to the medial rectus, and that's why the medial rectus, the esotropia here is very large in comparison to the primary deviation in the left eye. And this is called the secondary angle. When you have a paralytic squint, we have something called the, or concomitant squint, let's say, we have something called the primary angle if the squint is shown in the affected eye. But if this eye takes the fixation, we will the other normal eye will show secondary angle of deviation, and secondary angle is bigger or higher in the amount in comparison to the primary angle. I'm just revising some basic principles in order to understand the coming chart. So back again to the same case. So 6th nerve palsy here. Let's revise the changes in the muscle. So we have here lateral rectus under action because this is palsy. And the antagonist muscle here is, we have overaction in the medial rectus because this is the antagonist. Whenever we have a palsy, the antagonist and muscle underwent overaction or contraction. Let's say contraction. But the brain is always trying to stimulate the lateral rectus. The brain is sending impulses in a hope that the lateral rectus will function. So in the same time, there is also strong impulses to the medial rectus. So we have here also medial rectus overaction. And as you know, whenever there is impulses here, by Sherrington law, there is inhibitory impulses to the lateral rectus. So these are the changes in the muscle whenever we have 6th nerve palsy. So if we have a 6th nerve palsy, OS, we have lateral rectus under action in the affected eye and also in the contralateral normal eye, but this is called pseudo inhibitory palsy. It's not a true palsy. There is some limitation, there is some under action here, but this is called pseudo inhibitory palsy. And we have medial rectus overaction. Here we can say contracture, and here we can say overaction. Because all these findings will be shown in the chart, in the Hess chart. We will see it now. Let's see this chart. I will start by the right eye. Why I'm going to start by the right eye?
That is the abnormal eye, ma'am.
Yes. Why it is the abnormal eye? Because as you can see here,
under action.
Yes. Here, this is the in all lateral gaze here. So here, the lateral rectus, it should be here, but the patient points here. So there is here limitation. So simply you can say there is limitation in abduction. I forgot to mention that if we have a sixth nerve palsy, so sixth nerve palsy will affect the lateral rectus function only, right? So you might think that the limitation should only for abduction, but actually you will get limitation in up and out and down and out, because for superior rectus and inferior rectus to function, the eye should be the lateral rectus should be healthy. I will repeat it again. In sixth nerve palsy, which supplies only the lateral rectus, you will get limitation in abduction, right? But in reality, if you see a case of sixth nerve palsy, you will find also limitation up and out, down and out. And why is that? Why the superior rectus and the inferior rectus is affected? They are supplied by the third nerve, not the sixth nerve. Because in order to demonstrate up and out and down and out, the eye should be goes out in the first place. So in sixth nerve palsy, we will get also limitation here. We will get also limitation down and up. So even in this is the field of the superior rectus and inferior rectus, and both are supplied by third nerve, they look like as if they are affected, but they are not affected. But this is because the eye can't move out in the first place. Okay, so in sixth nerve palsy, you will get limitation in abduction and also up and out and down and out. I didn't show you a case of a real sixth nerve palsy, but if you are searching or Googling for sixth nerve palsy in composite picture, like in all gazes, you will find also limitation up and out, down and out. But usually in the textbook, they will show you only the horizontal versions. They don't show you the other gazes. So the black here, the black line here represents the patient's response. So it should be here and became here. So this is a limitation. And what is the meaning of this arrows here? So this is arrowheads. This represent overaction. And as you can see, the overaction in the area of the medial rectus. As we said before, if we have a lateral rectus palsy in one eye, the antagonist medial rectus underwent contraction, or we can say overaction. And in his chart, it will be shown like arrows because it is beyond the margins of his chart. And how about the central point of fixation?
But I understood what you said. The center point of fixation is moved to the left, right? In the right eye. Okay, so here it should be here. This is the central point of fixation, but this is patient's response here. So it is shifted nasally. So this is an esotropia. So you can judge the alignment from his chart. This is an esotropia because the central point of fixation is shifted nasally. And for how much degrees? You can count the number of small squares. We have 3 squares here. So 15 degrees. 15 degrees, excellent. Now, this is called the charting of the right eye. It means that the right eye is not the fixating eye, and it means that the right eye is the squinting eye.
But when we chart the left eye, focus in this point. When we are going to chart the left eye, we agreed that the charting of an eye means the charting of the non-fixating eye. It means that the left eye here is the non-fixating eye, so it shows the secondary angle of deviation. So it means also that the right eye, which is the paralytic eye, is now the fixating eye because of the change in the goggles.
Yeah.
So in charting the left eye means the red filter in front of the right eye, and the right eye, which is the affected paralytic eye, is the fixing eye. And now the squint is shown in the normal eye. In other words, the secondary angle of deviation. This is as if you cover the affected eye. Now we are charting the left eye that shows the secondary angle of deviation. And as you can see here, this is a point of fixation. See, the patient response is here. How many small squares? 1, 2, 3. Let's say 4.
Almost 20.
So 20. So this is fulfilling what we said, or this in agreement with what we said, that the secondary angle is more than the primary angle. So here we have esotropia. And if you remember these changes in the muscle, the medial rectus here also overacting. Okay. And here is a pseudo-inhibitory palsy in the lateral rectus. So the line here is slightly show some limitation in the lateral rectus because this is pseudo-inhibitory palsy.
Yeah. If we have to describe this in exam, can I try, ma'am?
Yes, go ahead.
So first I'll comment on the abnormal eye. So this is a Hess chart. And the abnormal eye is the right eye. I can see there is limitation of abduction. I can just say abduction, no ma'am, I need not say.
Yeah, just abduction.
There's limitation of abduction in the right eye.
Okay, you can start. So remember the clinical, what you do in the, what you comment on the photos. You can start by the primary position.
Primary position is
the alignment. Esotropia, and you can impress the examiner by saying the amount of esotropia, like 15. Yeah, 15 degrees. Okay.
Okay, so there is esotropia, and the amount of esotropia is 15 degrees. Yes. And there is limitation of abduction in the right eye with slight overaction of the antagonist.
Medial rectus.
That is in the medial rectus in the right eye. Coming to the left eye, there is there is contralateral overaction of the medial rectus.
So again, comment on the squint. You have secondary angle of deviation. It shows secondary angle
deviation, which is 20 degrees.
Yes.
And there is overaction of the medial rectus in the left eye.
So you can say here, we have an overaction of the, if you are planning to impress the examiner, but I don't recommend this, we have an overaction of the contralateral yoke muscle, because medial rectus here is the yoked muscle too, yoked with the lateral rectus here. So we have overaction of contralateral yoked muscle, which is the medial rectus, and we have a slight limitation of the lateral rectus action, and this is called pseudo-inhibitory palsy. And
pseudo-inhibition, ma'am?
Pseudo-inhibitory palsy.
Pseudo-inhibitory palsy, okay.
There is a difference between horizontal squint and vertical squint. What I mean by this, if we have an esotropia here, if you cover this eye will move out to take the fixation, and it becomes like this. And at the same time, this eye will move in. So under the cover, it shows the esotropia. So we have, when we are dealing with horizontal strabismus, whether the strabismus is seen in the right eye or the left eye is still the same. So here we have esotropia and here we have esotropia. Okay, so whether the eye, right eye is fixating eye or the left eye is fixating eye, it's the same, esotropia. Okay, how about the vertical strabismus in general? So regardless of whether it is comitant or incomitant, if we have let's say hypertropia here, and this is the fixing eye. If we cover this eye will move down to take the fixation, but this eye is already central, so it will move down under the cover. So in vertical strabismus, one eye is hypertropic and the other eye is hypotropic. Okay. So you already see the comment here. This is a fourth nerve palsy. We didn't discuss the fourth nerve palsy, by the way, but at least you know it by heart. So we have superior oblique palsy, and superior oblique is depressor. Yes. Okay. Explain to us. I will take a break.
Okay. The abnormal right eye. Can I start like that, ma'am?
Yeah. The abnormal eye is the right eye. Okay.
Yes, there is hypertropia in the right eye, approximately 10 degrees of deviation, with underaction of the, should I say in underaction or limitation, ma'am?
Underaction.
With the limitation, underaction of superior oblique in the right eye, with corresponding overaction of its antagonist, that is inferior oblique in the right eye. Coming to the left eye, there is hypotropia of approximately 5, 10, 15, 20 degrees in the left eye.
It's higher than or bigger than?
It's higher than the right eye. With the corresponding overaction of its yoke muscle, that is inferior rectus, ma'am. And pseudo-inhibitory palsy of superior rectus in the left eye.
Yes, excellent, excellent. Better than me. So remember the physiology. So you answer it correctly without knowing what is happening in the eye. So without knowing the basics of his chart. It's like an ECG, EEG, ERG. You can elicit the findings, reach to diagnosis without knowing everything what is happening actually in the eyes. So just remember.
So I can. Yeah, so finally I'll tell that so this is a case of right superior oblique palsy with secondary deviation in the left eye greater than primary deviation. That much is enough, ma'am. That is how we can conclude.
Yes.
Yes, okay, ma'am.
And as you said, as you see, Kanetsky mentioned it is a recent or so recent acquired. This is an additional information. Recently, because you will see in the next slide. This is related to the physiology again. So in nerve palsy, over time, the incomitant strabismus, there is something called spread of comitance. Spread of comitance. So that the secondary changes in the muscles will change the appearance of his chart. And so in order to do his chart, there are two essential requisites before doing his chart. Or let's say, so something called the normal retinal correspondence. So again, you couldn't understand this, or maybe you couldn't understand this because you don't know the basics of his chart. So it should be normal retinal correspondence. It should be a cooperative patient. So we don't use it. Do it for children, uncooperative children, non-cooperative children. And the last requisite, I shall add, there must be no suppression. So if we have a suppression, because we are charting something called the foveal projection. So if the fovea in the squinting eye is suppressed, deeply suppressed, we are not able to do his chart for this patient. So ignore the recently and acquired. This is additional unnecessary information. Just say this is a fourth nerve palsy, and don't forget the side, the right eye, and comment on the ocular alignment in the primary position, which is hypertropia by the amount of degrees you see.
Yes, ma'am. Ma'am, and always before doing his chart, the head posture should be corrected, ma'am.
Of course, yeah.
Yes, yes. And with full glass correction it is done.
Yes, refractive correction. And you know the relation between the degrees and the prism. So if we say this is a 15 degrees, it means approximately 30 prism diopter.
Okay, ma'am. Double,
yeah. And here from Kanisky, so it could be congenital, but without suppression, because the child may or the patient adopted abnormal hip posture, so he avoids the suppression and the other complications. So this is let's say congenital or long-standing forced nerve palsy, and as you can see the chart, slight limitation here in the superior oblique and slight overaction here in the inferior oblique. But still here, the pseudo-inhibitory palsy of the superior rectus. And yes, so all the finding is still there. And we have here hypertropia and we have here hypotropia. But as you can see, it's when you see the secondary angle closer to the primary angle, it means there is a spread of comitance for this. Yes, there is somehow changes in the muscle to keep the squint as comitant, as if it is comitant.
So if we don't have this description below, whether congenital or acquired, so based on this amount of deviation, we can say it is comitant squint, right, ma'am? Because the primary deviation is equal to secondary deviation here.
But again, you will get in trouble. So if it is comitant, why there is under action in the first place? Yeah. So once there is under action, because in comitant, the chart should be normal. So if it is a pure comitant, it should be normal action in every position. Remember, the comitant strabismus, we have full action for each muscle.
Oh, okay.
So suppose that we don't have the comment, you notice this hypertropia here, under action in superior oblique, overaction in the antagonist muscle, and overaction in the contralateral yoke muscle, and pseudo-inhibitory of the antagonist of this muscle. Here hypertropia, here second angle hypotropia. So despite the fact that there is, they are equal, but the abnormal side is the side which shows under action. So here we have under action here, and we have under action here. So which is abnormal? Knowing that the, so it's very hard to have isolated superior rectus palsy.
Yes.
The common is common. So we commonly, this is a case of forced nerve palsy.
Okay, ma'am, got it.
So when you study for the first time, you read the comment carefully. But during the revision, if you have a time to revise, you try to expect the finding before reading the comment again. Dr. Eva, do you want to comment on this one? We don't have a clue here.
So here the left eye is the affected eye. There is exotropia.
All right. So we have
10 degrees.
So sorry for the bad quality, but I brought this chart because it is more clear than that is in Kanisky. So actually there is exotropia. This is number one. Okay.
About 10 degrees.
Yes, excellent, 10 degrees, because this is the central point of fixation. So we have 10 degrees here, exotropia. Coming now to the, so the limitation or under action of the muscles. Here. Let's go muscle by muscle, okay? Here, the superior oblique. It should be here, but it is there. So we have under action in the superior oblique, all right? And here, the inferior oblique also. And here is the superior rectus also. And here is the inferior rectus also. How about the lateral rectus?
Okay, lateral rectus is fine.
So all muscles are affected except the lateral rectus, all right?
Okay.
And this goes by the alignment, because exotropia with a normal functioning lateral rectus. So we are dealing with paralytic or restrictive. So you think about third nerve, because this is the most common cause for paralysis. So in comitant exotropia. But again, look at the action of the superior oblique. It is limited, but not as the others. So the superior oblique actually, in this case, let's say it in another way. In order to demonstrate the action of superior oblique, the eye should be adducted in the first place. Yeah, but since the adduction is affected because this is a third nerve, the superior oblique seems to be underacting, but actually it is functioning. And there is another clue that there is some slanting toward the superior oblique, or the least affected one. Yes, so here in this chart, all muscles are affected except the lateral rectus for sure. And the superior oblique seems to be underacting because the eye can't adduct in the first place. And we have exotropia.
Third nerve palsy.
Yes, third nerve palsy.
But there should be down and out. Yeah, there should be even some hypotropia, no, ma'am, ideally.
So, the majority of cases of third nerve palsy, I learned this from one of my professors. So the majority of third nerve palsy don't show hypotropia, because hypotropia, or in order for the superior oblique to function, it should be the eye should be adducted, and here we have exotropia. The superior oblique can't show the hypotropia because the eye is exotropic. So hypotropia is not always there. Hypotropia is not always there in third nerve palsy. So this is a case of third nerve palsy in the right eye. Let's see here in the right chart. Actually, this square, this field represents the inner field.
There is overaction.
So the outer field couldn't be charted in this right eye. We have overaction of all muscles. So all these affected muscles, we have contralateral overaction of their yolks. This is the smallest square. So as you see, the medial rectus, which is the yolked for the functioning lateral rectus, is normal, because the medial rectus is normal here because the lateral rectus is normal here. So other than this, there is overaction of the muscles. Again, here the lateral rectus is normal. The yolked muscle is normal also, because we get overaction for the paralytic muscles here. So here in inferior oblique here, the superior rectus here is overactive. For example, let's say it in another way. There is a huge expansion of the inner field because many muscles underwent overaction. Coming now to the last slide here. This is the field of the left eye.
Yes, left eye, elevation and
depression. Yeah, we have restriction, elevation and depression. What about the primary alignment?
Hypotropic.
Hypotropic and a little bit
and outward.
Yes. So this is from Kansky, as you know. So this is a case for blowout fracture. So we know when the inferior rectus is entrapped, there is damage for the inferior rectus, so we will get limitation in down gaze and limitation in up gaze, and that's why we have limitation in both gazes, and we have a hypotropia in the prime position. And in the chart of the right eye, there is overaction of
the contralateral muscles.
So because elevation is affected and depression, so we have here overaction in elevators and depressors. One last question. You said that this is the affected eye, so this is the primary angle of deviation, and it seems to me that it is about 5 degrees hypotropia. Okay?
Yes.
Ignore the exotropia for a while, but it is 5 degrees hypotropia. This test is depend on cooperative patient and also meticulous technician. So here, ignore the horizontal component. In the primary deviation, we have 5 degrees hypotropia, but here the secondary deviation is like ortho. Do you have any explanation for this?
The left. What did you say? The right eye it is?
There is
no, ortho.
Yeah, we said before, if we have an hypotropia in one eye, and now we are charting the right eye. So when charting the right eye, the affected eye, which is the left eye, should be forced to take the fixation. So there should be hypertropia in the chart of the right eye. When we have yes.
There is this tells that this is restrictive pathology instead of paralytic pathology. So
yes, excellent.
So it can't take the fixation.
Yes,
in the
excellent,
right.
Excellent. So we have here a restrictive hypotropia, and if we do cover test, if you cover the right eye, the left eye can't take the fixation. It is restricted. This is frozen down. Okay, and that's why even though right eye, the chart of right eye didn't show the hypertropia. There is another test that doesn't require red-green goggles, and it's called Lee's screen. So the idea is they call it dissociate. So the right eye sees something, and the left eye sees something. So actually, here the image is not clear, unfortunately, but there is a mirror like over the nose, let's say. So the right eye is seeing this chart, and the left eye is charting, is pointing. Anyway, so Lee's screen doesn't require red-green goggles. So in if you remember his chart, because of the red-green goggles, the right eye sees something and the left eye sees another thing. Again, here, by the use of the mirror here over the nose of the patient's nose, the right eye in this side sees the pointing of the technician, but the left eye is supposed to point. And there is a grid here also. So if the technician is pointing here, the right eye sees this, but the left eye is supposed to point exactly at the same point as the technician points. I don't know if you got it, but anyway.
Yes, ma'am. Based on the reflection from the mirror, ma'am.
Yes. Finally, we finished this series.
Thank you so much.
Thank you so much, ma'am. Really, thank you so
I
much.
hope you are now different a little bit from before this.
Definitely. How to tell a his chart, definitely I can tell more confidently now. Right, Eva?
Good luck.
Okay, thank you, ma'am.
Thank you so much, ma'am. Bye, ma'am.
See you. Bye-bye.
Oh, a million dreams for the world we're gonna make.